next it's my pleasure to introduce Klaus Kenn, who's probably working in the nicest area of all pulmonologists in Germany, I would say. Where others make holidays, he's working, but he's leading the leading rehab center for pulmonology in Germany. And I've been there many times, and you can learn how you can put patients with an FEV1, I think, of 10% on a treadmill with an NIV and get them to exercise. And so with that, the team has also worked a lot on trying to give patients with medical devices the ability to be active, to prevent, for example, what Jean-Louis showed, the muscle wasting, which is one of the major problems that we have in COPD. So we're thrilled to have you here, Klaus, and we're very interested to hear from you. What can we do to keep our patients more active, to keep them in better shape with their chronic disease? Thank you.
Thank you, Holger. Dear Chairman, ladies and gentlemen. As you have heard, I'm working in a rehabilitation unit, and you may ask why this is now a topic after these two talks about very severe disabled patients who are not able to do almost anything. And what I try to do in the next minute is to show that also for those very advanced COPD patients, the ability to perform any kind of physical activity is very important. These are my conflicts of interest. This is the agenda. I will try to go with you through in general to highlight the role of physical activity for all of us, the importance for the COPD patients, and the additional effects of long oxygen therapy or additionally also non-invasive ventilation in those patients. So physical activity is something we are losing over time, as you all know. And you see here the one guy on the computer. You could also see the couch potato topic people. And we lost most of our daily activity we performed in older days. And a very pronounced ability or status of being active is COPD patients who is ending at the wheelchair, and wheelchair means no physical activity. And we know from many studies that physical activity is anti-inflammatory, and being inactive is pro-inflammatory, so that's basically a very good thing to have or not a bad thing not to have. And we know from studies, and I only want to show you one from the United States, 55,000 people from Texas, and they were observed over several years, and they looked for the all-cause mortality and the cardiovascular mortality. And to make the long story short, the difference was seen after 5 to 10, other studies show 15 minutes of slow speed jogging or walking per day, and you see tremendous effects on all-cause and cardiovascular mortality, and being more active doesn't change too much more. So basically to do anything is a very good thing for us to keep in mind. And to put that in relation to another thing we are really scared of, the role of smoking in terms of risk of death, you see that inactivity is as potent or as dangerous as smoking is. And so we should also put that on our list to defend not only smoking but also inactivity. And last year at the ERS in London, I've seen this poster in the tube, and that was from the Restaurant Association telling eating doesn't kill you, but sofas do. And the next slide shows the tremendous combination of both, a really killing combination, but this is what we see in young people today and also sometimes in our patients. And I'll go to the COPD patient. Do we have the idea that those patients may have the ability or the motivation to do anything physically? Mostly not. And also the patients don't do that because they can't imagine that they really can get out of their resting position. But the good thing is this is not true. And all the data from Spain show, and to take that in account, it's questionnaire-based assessment, so I'm a little bit scaring about the value of this data, but they nicely show that over 20 years, the time to readmission and time to death is definitely depending on the activity level. And the same is seen in a prospective, well-done study from a Hamburg group, showing that COPD patients with severe to moderate intensities really show a tremendous difference in between being active or inactive in terms of mortality. And so inactivity is really something we have to put on our therapeutic goal list, and not only to keep them alive, but with non-invasive ventilation, but also to see what they can do in combination with that. And when you look for parameters for all-cause mortality, you see that physical activity level is the most prominent compared to lung function data, 6-minute walk data, quality of life, or body index, or MRC dyspnea index. So that's to be taken in account. And depending on the stage of COPD, patients lose about 1,000 steps per day over a time period of 3 years, and independent of the stage. Now the question is, what means 1,000 steps a day? And I show you recent data where they try to elaborate a minimal important difference for physical activity. And the message is that something in between 600 and 1,100 steps per day is clinically meaningful. So this 1,000 steps per day lost is clinically negatively meaningful. And when you then subdivide this group in people being less active, that is physical activity level below 1.4 means sedentary, sitting on the couch, and these patients are at least walking or doing something during everyday's life. And this kind of 1.4 really shows that 6-minute walk difference are markedly, and also the loss of fat-free mass, that muscle mass, is also very much more pronounced in this inactive group. So the next question is, what can we do with oxygen? There have been a lot of studies showing that oxygen for non-hypoxemic patients doesn't help too much in order to increase their abilities to be physically active. And so we performed this randomized controlled trial in a crossover setting. And the patients were blinded for the gas. Either they received compressed air or oxygen with a 2-liter dose. And we subdivided these patient groups in 2 groups, the non-hypoxemic, the hypoxemic only during exercise, and the hypoxemic already at rest. And you can see here, these were definitely more pronounced disabled, also in terms of measurement. And what was the outcome shows that if you take here a cutoff of 88% of oxygen saturation, the non-hypoxemic patients didn't benefit too much, and they really didn't need it. The patients with hypoxemia on exercise definitely benefited more, and the best effect was seen in those who were really hypoxemic. And you couldn't prevent the drop in the saturation, but at least it was on a much better level. And you have to keep in mind that it was just strictly 2 liters and not individually adapted. And I think when we give those patients then their really needed dose of oxygen, this curve may be even better. And if you look now for the effects of medical air and the hypoxia group and the hypoxia on exercise performance group, you see that there are on baseline definitely significant differences, but the group with the lowest baseline 6-minute walk had the highest increase in 6-minute walk, and this was definitely beyond the minimal important difference that is discussed at 30 meters. Now another aspect, what we should also keep in mind, how we get the oxygen into the patient's lung. And that's not only depending on the machine, if it's liquid oxygen or an concentrator or what kind of concentrator, but I think it's also depending on the device we use to transport this oxygen. And there's a very old device, mostly forgotten, was developed in the United States. And the tube is about of this size of my finger, and there's a reservoir where you can increase your FeO2 by each piece. And we performed a randomized crossover trial, and we could see that using this, the oxygen saturation was at rest a little bit better, but during exercise at isotime with the oxidizer it was definitely and also significantly better. The endurance time was increased by 92 seconds, and what does that mean? Here the minimal import difference is discussed to be above 105 seconds, so the overall aspect would be that's not very effective. But when you then subdivide these patients in so-called low flowers or high flow patients, you see that the patients who really need 4 or even more liters during exercise, they really benefit just by changing the device. They have an increase of 35% in endurance time, and I think this is worthwhile following. Now, what may be the role of non-invasive ventilation in COPD patients? There was a nice study from the Netherlands in 2011 showing what's happening with COPD patients admitted to rehabilitation when you either implement non-invasive ventilation at nighttime or not. Both groups had a 3 months inpatient rehabilitation with all these components that belong to that. And the intervention group kept on performing non-invasive ventilation over the time. And you see here, with regard to the 6-minute walk distance and also for the blood gas parameters, the group with the non-invasive ventilation went markedly better over 2 years. And this affects what was seen after 6 months could be sustained or sometimes even more pronounced after 2 years. So that this seems to be a helpful, useful tool to stabilize those patients in order to also prevent deteriorations. But this was nighttime non-invasive ventilation. Now the question is, what happens if you give patients non-invasive ventilation during exercise? And when we first presented this at an ATS about 12 years ago, there was a lot of rumor in the room, and that these Germans are crazy to do that. Today, we are happy that a lot of groups are doing this, and I show you data from a small group of patients. You see here 20% predicted PCO2 at rest, 48 millimeter mercury, and we performed an endurance test at 70% of the peak work rate with or without non-invasive ventilation, and repeated that 1 hour later. And you can see here that the endurance time was markedly increased with non-invasive ventilation. It was 126 seconds, that's more than 105. And the saturation at isotime was better, the CO2 at isotime was much better, and heart rate was comparable. And over time, you see here that the oxygenation with non-invasive ventilation was kept above a normal level, and without non-invasive ventilation it dropped down, but with the support of oxygen it was not below 90. But here you can see the levels of CO2 without non-invasive ventilation. They started at 49 and went up to 53 or 54. And the group with the non-invasive ventilation also showed an increase, but on a much, much lower level, so that we can show that this is a safe thing to do, and it really is realized by the patient because he can do better and perform the exercise longer. And in the most disabled patients awaiting lung transplantation, and we are a referring center for those patients, we took analysis of more than 1,000 transplant candidates, and out of these, almost 300 were came on or were set during rehabilitation on non-invasive ventilation. And as you can see here, they started, as one could expect, with a lower baseline 6-minute walk, but the increase, despite of the fact that they were really more disabled, was even higher than with the so-called normal rehabilitation group, and the difference was just significant. The changes in health-related quality of life were comparable about in both groups. So to conclude, we think, and there's a lot of data to show that physical activity is the most important and potent drug on Earth. We only can't put them in pills, otherwise this would be a blockbuster. Patients with advanced COPD basically show sometimes very limited physical activities. They have no idea, no fantasy to get out of their wheelchair or their sofas. We know from studies from the 1980s that giving oxygen may prolong lives, but the data are not very good in comparison what we would expect today from data. We know, for example, from the Kenn study, that a well-established non-invasive ventilation and stable hypercapnic patients really prolong their lives. But we think, and that's our daily approach, that the combination of long-term oxygen therapy, non-invasive ventilation, and rehabilitation, meaning increasing physical activities, put them on the treadmill or on the bicycle with or without non-invasive ventilation, really may help not only to prolong their lives, but to give their lives better health-related quality and better participation of daily living. And I think this is something those disabled patients really suffer from, and their participation in social life and family life is very, very poor usually. But we have one big step to go. And to be honest, we don't have an exact and very good idea how to do or to go this step. I just showed you data about improving capacity. We trained the patient, we educated, we motivated, and we could see when we then measure it, it's increasing. But when we then look what's happening with activity and daily activity, if you measure this with activity monitors, these data are very, very disappointing for rehabilitation doctors. Because despite the fact they can walk longer, they can work quicker, they don't do in their daily life. And therefore, I think for too long time we forgot, beside of training muscles, to focus on the most important thing, what we should focus as doctors in treating patients, to change their behavior, to change something in their mind, to say, okay, I know I can do that and I will do that. And I think that's a challenge that's not really solved as a future question. Perhaps we must be innovative. Last year I've been at Brussels airport and I was wondering why this fat guy was cycling. And I went around and the solution was he was reloading his cell phone. And so perhaps what we also need is something like Pokemon Go for COPD patients. That means we have today very brilliant, intelligent devices. And now we have to find solution to adapt our patients to those ways. And I think that's the future of especially COPD patients getting more active, and perhaps that will be happening in the future. But it's not only a question of patients. That was at the ATS in San Francisco 2012. You see, we as doctors have also to learn a lot. And with that, I thank you for your attention. Thank you.